Hello, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. ICOS is a world leader in education and advocacy for the field of cardio-oncology. Today you will hear a highlight from a recent webinar on AL amyloidosis. The discussion is led by Dr. Daniel Lenihan and features an international panel including Drs. Wechalekar, Palladini, Cheng, and Milani. The discussion is both very practical and forward-looking, very clinical and thought-provoking. You will certainly want to visit the ICOS website for information on a variety of topics, including the upcoming GCOS Summit in Madrid, Spain, that now features a virtual option. Without additional delay, here is the discussion led by Dr. Lenihan.
I did want to ask Dr. Wechalekar at least one question about the GLS data that he showed. You know, one of the difficulties that we have in our case illustrates this, that GLS is not always measured, and then serial measurements are not always done to the same quality as what they were at baseline. So what is your experience there, or what are your thoughts in regards to that as a tool to follow cardiac response?
Thank you, Dan. That's a really important point because GLS is very much operator dependent, but I think different machines, and I'm not a cardiologist, but my understanding is different machines and different operators have different ways of measuring GLS, and therefore, you know, the interoperability of GLS across machines and across echoes may not be the same. I mean, we are slightly privileged in our center because we've got a limited number of echo technicians who would repeat the measurement on the same machine. So our measurements are pretty reproducible. And certainly the coefficient of variance for our measurements was about 1.1 to 1.5, and therefore we chose 2 as the change. However, we need to show that this is really reproducible across different centers, different countries, before we can adopt it. However, if you have an echo where you can go back and re-look at the GLS, then that is what would be my suggestion. Is if you were looking at a change in GLS, if you had some data, you can go and re-measure it, get the same operator to look at it. But yes, it's a problem. And I think it does need standardization in terms of measurement when amyloid is suspected. But I don't think it's something that's routinely measured. Even in the UK, we don't get GLS routinely on our patients unless we ask for it specifically.
And then Dr. Milani, you had a few slides where you had a genetic profile, you know, certain high-risk patients with the T1114 mutation. I'm curious, do you do that routinely in all of your patients? Does that really help you? Because, you know, we do that for, you know, anybody with ATTR. We always want to measure for TTR mutation, and then frequently we do other mutations, but that being the most important. Do you think that that is a mutation that we should measure in all the AL patients?
Well, just to clarify, this is cytogenetic abnormalities in the bone marrow evaluation, so are not genetic tests on our patients, but on the clone. So we need to have data regarding the characteristics of the clone of our patients, and so we really suggest that all of our patients have to be tested for cytogenetic abnormalities in their bone marrow at diagnosis in order to have the correct treatment strategy for the subsequent treatment. Also because, as mentioned, for example, the presence of translocation 1114 could be associated with a higher likelihood to respond to specific treatments such as venetoclax, but also because now we have data also about other cytogenetic abnormalities such as the gain of 1q that is associated with a reduced response to methyl and dexamethasone and also other regimens. So we strongly believe that also the evaluation of cytogenetic abnormalities in the bone marrow is an important step at diagnosis for our patients.
Is that, sorry for my ignorance, but is that something that is routinely ordered? Like when somebody does a bone marrow, do they routinely do that?
Yes, in referral centers, it should be routinely evaluated. And also in some cases, we can also, for example, in our center, we are collecting also, we are planning to collect also samples from other non-referral centers in order to allow them to have routinely also those important data.
Fantastic. Thank you.
I think those were all such wonderful talks. I do have a bit more of a general question for all the speakers. So there was a lot of comments and data showing that earlier diagnosis is always better. I'm curious what your thoughts are in terms of how we can achieve an earlier diagnosis. As you know, there's been some data showing you could potentially use EHR machine learning, but it's not really been implemented. I want to see what your thoughts are in terms of routinely screening patients, for example, with some type of modality in a community for amyloidosis.
Yeah, Dr. Palladini, I wonder if you could comment on that, because as if you're a major referral center, everybody that comes to you probably is, that the diagnosis is established.
Yes, it is easy to work in a referral center, of course, because all the hard work of thinking of the disease and doing preliminary testing has already been done. So that's true. The problem in screening for AL amyloidosis is that AL is a rare disease. So you will have to enrich the sample in order to have a pre-test probability that is high enough to render mathematically affordable the testing, of course. So Professor Merlini and I have been advocating screening in patients with a monoclonal gammopathy of undetermined significance and high free light chains. These patients are usually followed by hematologists with a regular follow-up for this condition, for MGUS. And it is known that symptomatic amyloidosis arises in patients who have had elevated free light chains for at least 4 years. So we have a population at risk. And what we are suggesting is to look for elevated biomarkers of organ involvement, for instance, BNP or proteinuria in these patients during the regular hematologic follow-up. What we don't know is the cost effectiveness of this approach. So how many patients will we really be able to identify who will really have AL amyloidosis? And a study is ongoing in Italy, and the first data will be presented at the Heidelberg Symposium in September. So we hope we will be able to be a bit more convincing in the future. Of course, the problem with biomarker is an issue of specificity. Of course, BNP and albuminuria will not miss renal involvement and cardiac involvement, but they will find many other things, particularly BNP. What we think is these other diseases will still be worth knowing for the patient and physicians, but this is something we will have to prove, of course.
Yeah, that's a great point. I mean, if you do an NT-proBNP or a BNP and it's abnormal, and ultimately you don't make a diagnosis of AL amyloidosis, you still made a diagnosis of heart failure. So that's an important condition to detail. But as with the case that I showed, the window for opportunity was in that patient. She had a fall and she broke her wrist and went to an emergency room, and just the basic stuff was so abnormal, is you can't let it go. So I guess I would say, in the situation where you see low voltages on the EKG, or you see troponin elevation or NT-proBNP or BNP elevation, and you don't have an obvious explanation, you need to pursue it. And that's probably the main point. You're right. Just screening everybody with biomarkers is probably not an effective strategy.
And can I ask sort of a follow-up question? So along those lines, when you do find some abnormalities, when would you recommend referring a patient to, for example, a more specialized center? And do you recommend patients get their treatment there versus a shared care approach? I know every region has its own variation in the healthcare system, but for example, I can tell you in our region, there's a lot of distance between where patients live versus coming here. And the question is what you guys do or what you recommend in terms of how patients should harmonize this.
Yeah, I think Ashutosh, I think you have a lot of experience with that in the UK. Is that correct?
I mean, we've certainly got an approach of central assessment, as does Professor Palladini and Paolo, because we follow very similar models in terms of how the patients come. I think the patients who are very advanced with unstable, multiple complex problems are better treated in referral centers. But patients with early stage disease, such as stage 1 disease or maybe early stage 2 disease, the treatments are much more straightforward and could easily be treated by an experienced hematologist who has got experience in treating myeloma, but with a backup from nephrology and cardiology. So I think all amyloid patients need backup. If an individual hematologist with no backup is treating a patient, it becomes really challenging. I do feel that a small amount of experience in treating complex plasma cell dyscrasias is important in treating amyloid. So, these patients are better treated by a myeloma hematologist than by a very general hematologist. If there was an option there of going to somebody with myeloma experience, then they've got experience in using these complex drugs. And I think it is unrealistic to expect that all patients will be treated in the referral center because of volumes, logistics, travel. A lot of chemotherapies involve frequent weekly travel. So our other approach is we often treat the patients in our center for cycle 1, which is when we really need to optimize them and get the treatment sorted out, and then really hand them back to the referring center with a treatment plan where we've actually optimized the drug doses and what the patients are tolerating, and then see the patients back 2 or 3 months down the line.
And is that, you have a similar experience with that, Dr. Palladini?
Yes, we try to do the same. We, of course, the numbers are too high, and we cannot even deliver the first cycle at our center. So we act as a network. We coordinate a network of, I would say, almost 50 centers, hematology centers all over the country. So we do the first evaluation, and then we follow the patients with telehealth and regular meetings with the treating physicians, so that we can act as a backup. And also, these centers are acquiring some experience, because they do not see hundreds of patients, but they see tens of patients every year. So we try to create to spread the expertise in the country through the network. And I must say that our new telehealth approach that Paolo actually is in charge of is giving us some very good results and feedbacks, even in dealing with treatment toxicity, not only cycle by cycle, but also infusion by infusion. So this is still labor intensive, of course, because I think we have now more than 100 patients that are actively undergoing chemotherapy. So we work a lot over the internet and over the phone, but the results are good for diagnosis and follow-up.
That's a lot of patience, Paulo, to be on that many Zoom meetings. That's impressive. So Richard, how do you guys do it in the Seattle area? Do you have a sort of a network of people that you work with?
Yeah, no, I think that's a very good question. I think our model is a bit similar to some of these other centers because since we served the entire WWAMI 5-state region here, where South Carolina's Fred Hutch is a major referral center, but when patients are referred in, we tend to see them together as a group, and then their treatments are often initiated here. But if they're doing well, they get referred back to local community to complete their treatment, and they come back if there's issues or if they need to undergo a stem cell transplant. So one of the reasons why I was asking, I'm curious what other centers do, is because there's always this question of, their level of treatment may be a little bit better at a major referral center, but for patients who are getting treatment so frequently, it's very difficult for them to travel several hours, for example, every time they need a treatment dose.
Yeah, I think, logistically that is so challenging, but I think the other piece is, making sure that places are aware what these telltale, signs of disease are so that we can detect the problem at its earliest stage. And that's going to be an educational effort that we need to continue to emphasize. How do you measure these things, or what do you do to pursue somebody that had 2 abnormal troponins, for example? I mean, I'm sure that you've seen consults where somebody's been cathed 2 or 3 times because every time they come to the hospital, maybe with shortness of breath and their troponin is elevated, they want to exclude a coronary syndrome. So, I don't know if you've seen that, but I certainly have seen that many times. And, you got to start thinking of other conditions in that setting. So.
What an excellent discussion that I'm sure advanced your knowledge in some fashion. Of course, this is just a small sample of the kind of education and programs supported by the International Cardio-Oncology Society. If you are not a member of ICOS, please join this important organization. You can do so at our website, ic-os.org. Our theme music is provided by Eli Brandt of Oberlin College. So until next time, this is Tom Murtaugh on behalf of the International Cardio-Oncology Society. Treat cancer, protect hearts.